Dear colleagues, a very warm welcome from my side. My name is Thomas Seufferlein. I'm a GI oncologist working at Ulm University Hospital in Ulm, Germany. And we would like to discuss today how HER2 is shaping the current treatment landscape for biliary tract cancer. And we will outline guideline-based approaches to first-line HER2-targeted therapies for BTC and give an overview of practice insights on HER2 testing and summarize the use of HER2-targeted therapies for BTC in the second-line and later line setting. So we have, of course, European as well as American recommendations, and the ESMO clinical practice guidelines say quite clearly that in the first-line treatment, we should use a cisplatin gemcitabine IO combination, either with durvalumab, cisplatin gemcitabine, or or with pembrolizumab, and both are recommended equally in the first-line setting. When we now look at the data itself, this is the TOPAZ trial and the KEYNOTE-966 trial, and we see that in the TOPAZ trial, the addition of durvalumab improved the median overall survival with 3-year follow-up from 11.3 to 12.9 months, with a hazard ratio of 0.74, and the median progression-free survival from 5.7 to 7.2 months. And pembrolizumab did a rather similar effect, 10.9 months to 12.7 months with respect to median overall survival, hazard ratio 0.83, and then median progression-free survival 5.6 months as compared to 6.5 months. Interestingly, there were no new safety signals, and the safety profile is consistent with what we knew before from pembrolizumab as well as from durvalumab. But as you clearly can see, with median progression-free survival times of around about 6 to 7 months, there is a definitive need for follow-up treatments after progressing on first line, which occurs between 6 and 7 months. BTC has become a very interesting disease with respect to molecular subtyping. Biliary tract cancers, as you know, is a rather rare disease, and now we have so many molecular targets in a rather rare disease. 3% of all GI cancers, but the 6th most common cancers of the alimentary tract after colorectal, pancreatic, liver, stomach, and esophageal cancers. The prognosis is particularly poor. The 5-year overall survival rate is just 10 to 40%. You see a huge variation because we don't even have really good statistics on that disease, and this is true even after resection. When we now look at the prevalence of HER2 alterations, and you already see that's a tricky bit, it's reported between 5 and 20%. So there is the very few systematic approaches, and of course, this is also due to heterogeneity of expression. When you look at the HER2 aberrations, according to the primary tumor site of biliary tract cancer, you see it's about 6% for intrahepatic cholangiocarcinomas, 14% for extrahepatic cholangiocarcinomas. So it does complement a little bit. What you don't see in intrahepatic, you have HER2 in extrahepatic predominantly, and particularly also in gallbladder cancer, which is important because that's a disease where we can do very little nowadays, and 18% for papillary cancer. So it's actually important for, I would say, the whole spectrum of biliary tract cancers. And HER2 signaling is interesting in a way because what we have a dimerization of the HER2 receptors with HER2 and HER3 and HER4. And this leads to activation of downstream signaling pathways we are very familiar nowadays. This is RAS, RAF, MEK, ERK, or on the other hand, PI3 kinase AKT. And this, of course, leads then subsequently to cell cycle progression, proliferation, and survival. So targeting HER2 is a very interesting option in biliary tract cancer. When we look at the recommendations, we have both recommendations from the ESMO as well as from the NCCN. And the ESMO guidelines clearly recommend molecular profiling when first-line systemic treatment is initiated, not upon progress, but once it's initiated in patients with locally advanced or metastatic disease, particularly in those at high risk of progression or recurrence. Bearing in mind that this is a difficult condition because it's very difficult to say upfront when you start first-line treatment who is at a particularly high risk of progression or recurrence. So we do that in each and every patient. The available evidence also shows that HER2 expression by IHC is best assessed using the criteria applied also in gastric cancer. And the NCCN says that testing overexpressed on amplification of HER2 is also recommended for patients with unresectable or metastatic gallbladder cancer, intrahepatic CCA or extrahepatic CCA. So it's the same spectrum. And NCCN says NGS can be considered upfront when limited diagnostic tissue is available. IHC FISH remains the most commonly utilized. Predominant limitation of testing in hepatobiliary tumors is the lack of specific guideline cutoff points, standardized algorithms to testing to define HER2 positivity by protein expression or amplification in hepatobiliary malignancies. And I would like to add another difficulty, particularly for the extrahepatic tumors. Sometimes it's really difficult to get sufficient amount of tissue because the tumors grow undermining of the epithelium, and even with cholangioscopy, we sometimes are not in a position to obtain really a lot of tissue. And that's why there is recommendations by pathologists saying, okay, when you have a good resection specimen or a large biopsy, you actually can define membrane staining in more than 10%, when you see membrane staining more than 10% of the tumor cells in your specimen. However, when you have a biopsy specimen, then it's important to look for membrane staining in equal to more than 5 contiguous tumor cells, because sometimes you might not have more than that. And if you have 5 contiguous cells that are HER2 positive, this would be an equivalent of a score of 3 plus. So one has to really make do because of this really lack of tissue in many cases to see that there is HER2 positivity. And that's why the NCCN sometimes recommends NGS. Problem is here that NGS is much more expensive than IHC, and it's not so frequently used in this setting. So that's why we have to be really be adaptive with respect to the criteria, how we assess HER2 positivity in the different scenarios. So we have again the ESMO guidelines, and the ESMO guidelines say we just focus now on the HER2 positive tumors, that either we can use trastuzumab deruxtecan in patients with HER2 overexpression and or HER2 amplification who have progressed on or are intolerant to a prior treatment. And the study was in this case was the Destiny 02 trial. And when we have zanidatamab, it's also recommended in patients with previously treated HER2 positive disease and has a high SCAT score. The difference between these two treatments is that TDXD is not yet EMA approved, whereas most recently zanidatamab has gotten approval in the second line setting also by EMA. FDA has approved both drugs in this setting. And we've seen now that FGFR2 fusions in particular occur in round about up to 15% of intrahepatic biliary tract cancers, and they are very well targeted with drugs we have nowadays available, like pemigatinib or futibatinib or tilingotinib most recently. So there is a huge a plethora now of targeting agents that, apart from FGFR2 fusions, we have IDH1/2 mutations. So we don't have only to analyze fusions with, let's say, Archer panels or hybrid capture sequencing, but also analyze the mutations, IDH1 and 2, which again occur in around about 10 to 12% of the biliary tract cancers. But then on top of that, we have BRAF mutations. Now, most recently, we have loss of MTAP, which is also an interesting target, targeting PRMT5 in this context. And of course, we have HER2 alterations in biliary tract cancer. I think it's very important to bear in mind HER2 is present in biliary tract cancer. It's heterogeneous, but it's prognostic, and we have to identify patients with an HER2 overexpression because we can target it. And we have now very efficacious drugs in doing so. And that's why it's really worthwhile testing, and it should be done. It needs an experienced pathologist, and it needs interaction with pathologists. Repeated testing may also be helpful because we see that HER2 changes during tumor evolution, treatment-induced tumor evolution. We have very little data in biliary tract cancer, but we know this fact from gastric cancer. So we might really be observant and see that we, if material is available, should do a repeated testing in a more advanced setting to see whether we can get HER2 expression there. And as already stated, there are very interesting therapeutic options available, and we should make them available also to our patients.
Hi, everybody. Thank you for joining us today. I'm Lizzie Smyth from Oxford, and today I'm going to discuss how HER2-directed therapy is redefining the treatment of biliary tract cancer. As noted in the disclaimer, I may refer to investigational or unapproved uses. Please interpret these within the context of current evidence. As we saw in the previous presentation, testing for HER2 alterations is critical in patients with BTC, as we have a growing number of targeted therapies that we can use to improve outcomes for these patients. In this presentation, we will review the latest evidence with HER2 targeted therapies approved in BTC, and we'll also highlight some of the emerging treatment options. So where are we with treatment for biliary tract cancer, HER2 positive or not? For years, gemcitabine and cisplatin was the only treatment option. However, this is now often combined with either durvalumab or pembrolizumab. But beyond first-line, outcomes have been poor, with median survival rarely exceeding a year and second-line chemotherapy having a very marginal benefit. However, the arrival of targeted therapy, HER2 being one target amongst several, including FGFR2 and IDH1, has really changed that picture. So first of all, let's look at the pivotal trials that have established this as proof of concept. First, I'd like to discuss zanidatamab, which was evaluated in the Horizon BTC-01 trial. Horizon BTC-01 was a phase 2b trial of zanidatamab, which is a biparatopic or bispecific HER2 antibody that binds domains 2 and 4 on HER2. In Horizon BTC-01, 80 patients with HER2 IHC3 or 2 plus BTC were enrolled. With a median of 29 months of follow-up, the objective response rate was about just over 40%, and the median duration of response was an extraordinary roughly 1 year. Responses were clearly stronger in patients with IHC3 plus tumors, which re emphasizes the importance of high expression for HER2 dependency and efficacy. These data have led to EMA and FDA approval for previously treated HER2-positive BTC with zanidatamab. Moving on, we also evaluated trastuzumab deruxtecan, or TDXD, in the Destiny Pan-Tumor02 study, which was in multiple HER2-expressing solid tumors. In the BTC cohort, which was reasonably large, 41 patients, the response rate was around 35%. The median duration was 11 months, and median overall survival just over a year. These results supported the FDA pan-tumor approval of TDXD, and TDXD, or trastuzumab deruxtecan, is now guideline recommended for IHC3 plus BTC after standard therapy. There are a number of other trials which have demonstrated the proof of concept for the efficacy of HER2-directed therapies in BTC. These earlier basket studies really laid the groundwork. For example, MIND Pathway compared trastuzumab and pertuzumab and achieved a 23% response. And another study evaluated tucatinib and trastuzumab with responses nearly 46%. Neither of these are licensed, but both do appear in guidelines and be considered where ADCs or zanidatamab is not accessible. So let's talk about the safety of these molecules. Zanidatamab, an antibody, is generally well tolerated. Of 87 patients treated on Horizon BTC-01, grade 3 events were uncommon. What we saw was 5% diarrhea, 3% anemia, and reduced ejection fraction, which is common in HER2-directed therapies, at 3%. Of all the patients treated, only one grade 4 event occurred. So we do recommend, however, routine monitoring for infusion reactions and cardiac function whilst being treated with zanidatamab. Let's talk about trastuzumab deruxtecan, a drug with which we are all familiar. With TDXD, there is a familiar risk profile of nausea, anemia, fatigue, alopecia, and neutropenia. This is chemotherapy. Generally, these are manageable by experienced oncologists. However, with Enhertu or TDXD, interstitial lung disease remains the key risk. Early identification of interstitial lung disease is critical. Corticosteroids are essential for grade 2 or greater, and with vigilance, most grade 1 patients can be rechallenged. However, with grade 2 or greater, we would recommend stopping treatment. Moving on to other agents, tucatinib and trastuzumab also have low discontinuation rates, grade 3 or 4 events in less than 25% of patients, and mainly liver enzyme rises common in this patient population or ILD. Overall, all of these regimens are tolerable with standard supportive care and monitoring. So, when we think about selection and sequencing of HER2 therapies for patients with biliary tract cancer, it's often important that we identify progression early, as these patients are prone to symptomatic progression and reduction in performance status. Ideally, HER2 testing should be performed at the earliest opportunity to identify patients who might be appropriate for these treatments. If patients have had significant toxicity from chemotherapy, an antibody like zanidatamab might be preferred. TDXD should be avoided in patients with risk factors for ILD. However, we also know that zanidatamab does cause a degree of diarrhea, so perhaps for patients who suffer with GI side effects, this might not be preferred. Regarding resistance mechanisms, these are at this point in time poorly described. We're aware that patients may have HER3 activation, increased MET signaling, and of course, clonal evolution of their tumors. All of these aspects are being explored, and rational combination strategies are emerging. However, at this time, no clear sequence of combination therapies are recommended. Where do we go next for patients with HER2-positive BTC? There are several trials evaluating these promising compounds, including zanidatamab and TDXT, in first line in combination with chemotherapy and in combination with immunotherapy. There are also next generation antibodies emerging, including novel ADC constructs with different payloads. In summary, what are our conclusions on treatment of HER2 positive BTC? Firstly, HER2 testing should be done as standard for all patients with BTC. Two drugs, zanidatamab and trastuzumab deruxtecan, have delivered clinically meaningful and durable benefit with manageable toxicity. The next frontier is overcoming resistance and integrating these drugs earlier into the treatment pathway for patients with BTC. I would like to say that HER2 targeted therapy has moved from experimental to evidence-based practice, which is an important shift for this challenging disease.
Hello, ladies and gentlemen, dear colleagues. My name is Florian Lordick. I'm a professor in oncology. I'm based in the city of Leipzig, and I'm director of the University Cancer Center Leipzig. In the previous presentations, we learned about HER2 targeted therapies for biliary tract cancers. In this presentation, we are going to outline guideline-based approaches for HER2 testing and HER2 targeted treatment for gastroesophageal adenocarcinoma. HER2 alterations are important because they are leading to aberrant signaling, and this includes gene amplification, HER2 protein overexpression, and to a much lesser extent, HER2 gene mutation. What is the prevalence of HER2 alterations in gastroesophageal cancer? For the classical type of stomach cancer, gastric cancer of the distal two-thirds, we count with 21% of HER2 alterations. For those cancers appearing at the esophagogastric junction, we are reporting 32% of gene amplifications, overexpressions, or the rare gene mutations. Both in the European guidelines from ESMO, but also in the North American guidelines from the NCCN network, we have recommendations how to test for HER2 in gastroesophageal adenocarcinoma. ESMO recommends that HER2 expression is measured by immunohistochemistry, which we often call IHC, and or amplification by in situ hybridization. The NCCN recommends a slightly different approach for patients with inoperable, locally advanced, recurrent, or metastatic adenocarcinoma of the stomach, esophagus, or gastroesophageal junction, for whom trastuzumab therapy is being considered, assessment for tumor HER2 overexpression using IHC and fluorescent in situ hybridization or other ISH method is recommended. However, there are some biological and technical challenges to HER2 testing in gastroesophageal adenocarcinoma, which you should be aware of. When we are investigating gastric cancer tumor samples, we see a much higher heterogeneity of HER2 expression than what we see, for instance, in breast cancer, which means the expression of HER2 in gastric cancer is more focal. And next to areas with a high expression, you can also find areas in the same tumor, in the same patient, with low expression or even with lacking expression. This means that in general, gastric cancers tend to be less sensible and less dependent on HER2 and less sensible to HER2 targeted treatments than, for instance, in breast cancer. This is probably also the fact why some of the previous studies that have been done, like, for instance, the Jacob trial, where trastuzumab and pertuzumab were combined with chemotherapy, were negative. Tumor heterogeneity may be one of the most important reasons for leading to negative results in some of the previous trials. In Germany, we did an interesting field study where we sampled materials from several centers, from many patients, and examined these samples for HER2 expression. We saw a lot of heterogeneity in these samples, and we also saw an important discordance rate between local testing and central testing. And interestingly, when we looked at the effectiveness of trastuzumab in the patients of who we got the data, the outcome data, we saw that trastuzumab tended to be only effective in those patients where we had a concordant HER2 examination between local and central testing and where the HER2 expression was more homogeneous. So this is a proof for us that HER2 heterogeneity may really lead to decrease efficacy of HER2-directed drugs. What are the consequences for our clinical practice? These are the proposed strategies to optimize testing. It's a lot about sample selection. HER2-positive gastroesophageal junction cancers are more frequently of intestinal type or mixed. Diffuse type, including signet ring cell tumors, are generally HER2 negative. In mixed type carcinomas, samples with a prevalence of intestinal type areas should be selected when performing HER2 evaluation. Given the issue of intratumoral heterogeneity in gastroesophageal specimens, testing of multiple biopsy fragments from a primary or and metastatic site or from the resected primary tumor is preferred. If this is not an option, testing a cytology specimen from an FNA cell block is acceptable. NCCN recommends more than 6 biopsy samples, but others have found 4 to be sufficient. In the current ESMO guidelines, we are recommending 6, but in some of the national guidelines, we are even moving up to 10. What we are doing in clinical practice is that we take as much samples as we can, of course, with the goal not to cause bleedings, not to put any threat to the patient. But I really must say the more the better. And one of our principles is to take it from different sites of the local tumor and, if possible, also from distant metastases. How do pathologists assess the HER2 status? Usually they are starting with an immunohistochemical investigation. If immunohistochemistry is reported as 3+, which is a strong staining, in at least 10% of the tumor cells, nothing else has to be done. The tumor can be called HER2 positive. If the immunohistochemical staining is only moderate in its intensity, which is called IHC2+, then pathologists by reflex are doing an in situ hybridization, such as FISH or SISH or BDISH. If this shows an amplification of the HER2 gene, plus the immunohistochemistry 2 plus signal, the tumor can be called HER2 positive. Anything less than that, immunohistochemistry 1 plus or 0, or no HER2 amplification on in situ hybridization, defines a HER2 negative tumor. In the current guidelines of ESMO, and we updated these guidelines in form of living guidelines, we are recommending that HER2 testing should be performed before a first-line treatment decision is taken, because without knowing the HER2 status, we do not know which monoclonal antibody or other therapy should be combined to a first-line chemotherapy doublet, which is usually consisting of a platinum derivative such as oxaliplatin or cisplatin and a fluoropyrimidine such as 5-FU or capecitabine. If pathology is reporting an IHC 3 plus HER2 staining in 10% or more of the tumor specimen, or an IHC 2 plus and a positive in situ hybridization, we add trastuzumab as a monoclonal antibody to the chemotherapy backbone. The other staining which is needed is staining for PD-L1, because if PD-L1 is staining positive, with a CPS, a combined positivity score of 1 or greater, we are adding pembrolizumab to trastuzumab and chemotherapy. So this is the current recommendation given by ESMO and by many other national societies. The recommendations from the NCCN network are pretty similar to what ESMO is recommending. There are several limitations of first-line treatment, which include survival benefits remain modest. Intratumoral HER2 expression heterogeneity results in subpopulations of tumor cells not effectively targeted by anti-HER2 therapy, leading to a suboptimal response and early progression. Drug resistance is a substantial challenge, particularly after failure of first-line trastuzumab-based therapy. What are we recommending in the ESMO guidelines for the best choice of second-line treatment? Traditional choice was a combination of ramucirumab and paclitaxel, or chemotherapy alone, such as paclitaxel or irinotecan, or even ramucirumab alone for patients who do not tolerate chemotherapy. But now we have a new option, and this is trastuzumab deruxtecan, an antibody drug conjugate, which we can and should use in second line if a positive HER2 status is still confirmed because before the initiation of treatment. It is important to say that in the ESMO guidelines, we are recommending rebiopsy before we are starting second line, following a trastuzumab-based first-line therapy. What is the reason for that recommendation? Many of the initially HER2 positive tested cancers are losing the HER2 positivity during first-line treatment with trastuzumab and chemotherapy. So only a subset, approximately 60 to 70% of these cancers, remain HER2 positive and are candidates for trastuzumab deruxtecan treatment in second line. Absolutely concordant with the ESMO guideline, also NCCN is recommending trastuzumab deruxtecan upon progression to first-line trastuzumab chemotherapy therapy for HER2 positive advanced unresectable gastric and esophagogastric junction cancer. So, how can we conclude? HER2 protein overexpression and gene amplification should be assessed before any treatment decision in advanced stage gastroesophageal adenocarcinoma. First-line standard for treating patients with advanced HER2-positive cancers is trastuzumab and platinum fluoropyrimidine chemotherapy, to be combined with pembrolizumab in case of PD-L1 and HER2 positivity. Finally, standard of care for second-line treatment following progression on trastuzumab treatment is trastuzumab deruxtecan, TDXD, provided that the tumor still stains positive for HER2.
Welcome, I'm Professor Erik van Cutsem. I'm a GI oncologist at the University of Leuven. And as we saw in the previous presentation, testing for HER2 alterations is critical in patients with an adenocarcinoma of the stomach or of the end of the G junction, as we have growing number of targeted therapies that we can use to improve outcomes of these patients. In this presentation, we will review the latest evidence with HER2 targeted therapies approved for adenocarcinomas of the stomach and the G junction. And we will also highlight some of the emerging treatment options. If we go back around almost 15 years ago, we published the data of trastuzumab in the TOGA study. Trastuzumab was added to a chemotherapy doublet, a fluoropyrimidine plus a platinum, and it was shown that patients with HER2-positive gastric cancer, that there was an improved survival, an improved progression-free survival, and a higher response rate. And according to the initial criteria of the study, the median survival went up from 11.1 to 13.8 months. And this was in patients with HER2-positive tumor, defined as an IHC3+ or a FISH-positive tumor. However, later on, we did retrospective analysis looking into patients with a strong HER2-positive tumor. And this strong HER2 positivity was defined as IHC3+ or 2+, followed by a positive test. And these criteria were adopted for approval in many regions, including Europe. And with this criteria, we can see that the difference with the addition of trastuzumab plus chemotherapy is bigger. Hazard ratio for survival was 0.65, and median survival went up from 11.8 months to 16 months. After this, there was a long period of standstill. There were different failures, different disappointments with the addition of pertuzumab with TDM1, until we saw the data of KEYNOTE-811 study, which led to a new standard of care for patients with HER2-positive tumors. And indeed, in the KEYNOTE-811 study, combination of a chemo doublet plus trastuzumab was studied and compared with the same chemo doublet plus trastuzumab, but plus pembrolizumab. Initially, all comers for PDL staining were accepted in the study, but later on we did analysis on patients with PDL positive tumors, leading to the approval of this regimen, chemotherapy doublet, trastuzumab, pembrolizumab, in patients with a HER2 positive tumor and with a PDL positive tumor, evaluated with CPS testing with a cutoff of 1. And indeed, if you look at the data, progression-free survival was improved, overall response rate was higher, and what is extremely relevant is that the overall survival was improved also with hazard rates of 0.8, with more than 3 months median overall survival difference, with in the pembro trastuzumab arm median survivals of 20 months. And this is now the standard regimen for patients with HER2 positive, PDL positive tumors, first-line treatment. An important step forward in our knowledge was also the data on the antibody drug conjugate trastuzumab deruxtecan. This was initially studied in Asian studies and later in a Western study. And recently we presented the data in second-line treatment of HER2-positive gastric cancer. The Destiny Gastrico 4 study randomized indeed patients between the previous standard paclitaxel ramucirumab with trastuzumab deruxtecan in patients who really second line after progression on trastuzumab-based regimen and who were retested again for HER2 positivity in the study. Median overall survival went up from 11.4 months to 14.7 months in second line with hazard rates of 0.7. Progression-free survival was better. Overall response rate was also clearly better with a difference of around 15% higher response rate for trastuzumab deruxtecan. And this regimen is approved now in many different regions and is a standard treatment, the actual standard treatment in second line for patients with HER2-positive gastric adenocarcinoma and G-junction adenocarcinoma. Of course, with the introduction of new agents, we have to focus and to discuss also some of the safety aspects. In the TOGA study, there was a slight difference in cardiac toxicity. 5% of patients in the trastuzumab arm, cardiac dysfunction, defined as a more than 10% drop in the left ventricular ejection fraction, compared to 1% in the control arm. This is clearly less than what we see in breast cancer, where patients are usually treated longer. In Keynote 811, we are faced, of course, with the toxicity of chemo and trastuzumab. And on top of that, we see a bit more, and that's logical. So immune-related adverse events, but no new surprises were found. Pembrolizumab led to some immune adverse events. They are well known. They are manageable. One of the most important was colitis in these patients on top of some of known endocrine adverse events. In Destiny Gastric 04 in the second line, we are faced with some specific toxicity of trastuzumab deruxtecan, and 13.9% of patients at any grade of interstitial lung disease when treated with trastuzumab deruxtecan. This is in the range what we see with other studies. There was no clear increase in left ventricular dysfunction. And in general, trastuzumab deruxtecan, compared to paclitaxel ramucirumab, some of the other toxicities were more frequent with paclitaxel ramucirumab. So clearly it's feasible, but the oncologists have to understand clearly some of the adverse events profile. We have seen that it's important to do further research in patients with HER2-targeted agents. We are moving the bar up, but interestingly, we see now many new different agents. One of them is the bispecific antibody zanidatamab, which has been combined in different studies with chemotherapy. Some of these data are still very early, but give some interesting signs of activity. Here we focus just a moment on the interesting zanidatamab data. In this study published recently, a response rate in 46 patients of 76% was reported, progression-free survival of more than 12 months, and median overall survival of more than 36 months has been reported. Quite impressive for this combination of chemo plus zanidatamab. So, of course, this has to be evaluated in phase 3 studies, and these phase 3 studies are ongoing at the moment. Recently, we saw also some other interesting data of another bispecific antibody, anbenitamab, which was compared to placebo with anbenitamab plus chemotherapy in a study coming from Asia in pretreated advanced HER2-positive gastric or G-junction adenocarcinomas. And the data in Asian patients was in second line was quite impressive. as was reported at the last ESMO meeting. An important increase, improvement in the overall survival, going up from 11.5 months to 19.6 months with hazard rates of 0.29. Of course, this is a study in Asian patients. We need confirmation in a non-Asian population in this situation. With all this, we will have more options in the future for patients with HER2-positive tumors. And so we will have to learn how to select the different patients. Of course, organ function, general condition are key. Biomarkers will be key in HER2-positive patients also. One of the important discriminators is PDL positivity in order to see whether we combine it with a checkpoint inhibitor. And then there is a lot of research ongoing also to look at further biomarkers to differentiate and to select these different agents. But efficacy is going to be important. And it's not unlogic to say that bispecific antibodies may against HER2 may be more active than for instance, trastuzumab alone. We have to prove that, of course, in further clinical studies. And of course, we have to understand much better what is going to be the safety profile and the toxicity of a bispecific antibody versus trastuzumab in general. HER2-targeted treatments for patients with HER2-positive metastatic or advanced gastric cancer have improved clearly the outcome in as well first line as second line treatment. As a first line, the addition of trastuzumab and in patients with PDL positive tumors on top of trastuzumab, pembrolizumab today. In second line, trastuzumab deruxtecan, the antibody drug conjugate, has also clearly improved the outcome. And they are the standard, but there is clearly much more to come. The bispecific antibodies such as zanidatamab, which is being evaluated in combination with chemo or chemo plus PD antibody, tislelizumab, may lead, according to initial data, to an improved outcome. Of course, we have to wait phase 3 studies. And with these new agents, the oncologist has to be aware of specific toxicities, ILD, checkpoint-related toxicities in the setting. Some of the bispecific antibodies may lead to GI toxicity and diarrhea, and that's crucial also in order that the patients can benefit maximally from the new treatments that are being integrated in the treatment algorithms for the practicing oncologist. Thank you for listening to me.